Glucose stability without medication, a longitudinal CGM case study number 1511, January 22, 2026. Gerald C. EclaireMD Foundation, category Diabetes Control. Preface: my medical research papers are independent works, not chapters of a book. Each paper is written to stand alone. Therefore, I restate relevant background information in each paper so it can be read and understood on its own. In 1995, I fainted at Hong Kong airport due to hypoglycemia. In 1998, during a random hospital check, my glucose level was found to be over 360 mg DL, and I was officially diagnosed with type 2 diabetes. Based on these two events, I have lived with type 2 diabetes for more than 30 years. Between 1994 and 2004, I experienced 5 cardiovascular episodes. In 2010, I was diagnosed with severe kidney disease, neuropathy that nearly led to toe amputation, and diabetic retinopathy that was close to the blind stage. These combined findings forced a dramatic change in my life. Starting from 2010, I terminated all ongoing work programs, including developing a medical AI platform, self-studying psychology, and running charitable programs for 250 children and women in need. I returned to Silicon Valley and began to self-study internal medicine, starting with type 2 diabetes and later expanding to all major mortality diseases that I personally suffered from. I spent the entire year of 2017 writing my first medical research paper, which was later published and presented at the WHO IDF Forum. From 2018 until today, January 22, 2026, I have written 15 single-author medical research papers covering obesity, diabetes, cardiovascular disease, chronic kidney disease, stroke, aging, and longevity, including conditions I have not yet been diagnosed with, such as dementia and cancer risk. During this journey, I have spent more than 8,000 hours reading over 10,000 published medical papers. I have worked 13 to 14 hours daily, 365 days each year, for more than 16 years. I completed this work without medical institutions, medicine professors, classmates, colleagues, associates, or patients. Introduction: from 2010 through June 20, 2025, I did not take any medication or vitamins, including diabetes drugs. During this period, I relied entirely on lifestyle control, including strict food portion control, carbohydrate and sugar limitation, regular walking, continuous glucose monitoring, sleep and stress management. On June 21, 2025, I suffered a hemorrhagic stroke at the Pontine location. After the stroke, I began taking 1,000 mg of metformin daily. This created a before and after comparison that allows direct evaluation of whether metformin changed my glucose control. Glucose data and observation: I examined two long CGM data collection periods. The first period spans 7 years, from July 1, 2018 through June 20, 2025, during which I took no diabetes medication. The second period spans from July 1, 2025 through January 22, 2026, during which I took 1,000 mg of metformin daily. Despite the addition of diabetes medication during past 7 months, my glucose results are strikingly simple. The average daily CGM glucose in both periods, based on 96 measurements per day, is approximately 113 mg DL. The results of these two periods, previous 7 years without medication and recent 7 months with medication, are remarkably similar. During the lifestyle-only period from August 1, 2018 through June 20, 2025, the average daily glucose peak was 112.91 mg DL. The glucose wave amplitude ranged from 72 mg DL to 171 mg DL. During the metformin period from July 1, 2025 to January 22, 2026, the average daily glucose peak was 112.77 mg DL. The glucose values ranged from 78 mg DL to 146 mg DL. This narrower fluctuation range is expected, given the much shorter observation period. The overall fluctuation pattern and distribution are similar. There is no visible downward shift in glucose level after starting metformin on July 1, 2025. In fact, the post-stroke weekly average EEG curve shows a mild upward trend. This appears counterintuitive. However, the post-stroke period is relatively short, only about 7 months, compared with the pre-stroke period of 7 years, which showed a concave downward pattern. This comparison is not based on a few days or weeks. It spans an earlier 7-year period without medication and a recent 7-month period with medication. In both periods, the glucose measurements were obtained using the same Libre CGM device. Lifestyle management details were identical in both periods. Lifestyle context: my lifestyle remained essentially the same before and after the stroke. Food portion size and carbohydrate or sugar intake were unchanged. However, two lifestyle factors did change after the stroke on June 21, 2025. After the stroke, my sleep duration increased by about 3 hours per day. At the same time, my daily walking steps decreased to about 50% of my pre-stroke level of 15,000 steps each day. Despite more sleep and less physical activity, my average CGM glucose did not change. It remained at approximately 113 mg DL, almost identical to the pre-medication Lifestyle-only period. This stability occurred both with and without metformin. Pathophysiological illustration of the observed phenomenon. The observed glucose stability can be explained using basic pathophysiology without invoking complex or speculative mechanisms. Long-term glucose control is determined by the balance among three dominant processes: dietary, glucose input sugar from food eaten, hepatic glucose production sugar made by the liver, and peripheral glucose utilization use of sugar by tissues. Over many years, sustained lifestyle control can reset this balance to a stable operating state. In my case, both strict food portion control for weight reduction and carbohydrates and sugar limitation for glucose reduction have reduced my external glucose load, regular walking and daily activity. IMPROVD peripheral glucose utilization use of sugar by tissues. Continuous monitoring reinforced behavioral consistency. Together, these factors reduce the burden placed on my pancreatic beta cells and suppressed excessive hepatic glucose output through non-pharmacologic means. When such a balance is maintained for many years, the metabolic system adapts. The liver produces glucose within a narrow range. Peripheral tissues develop predictable glucose uptake patterns. Daily glucose swings become constrained. The system settles into a stable range. Under these conditions, adding metformin does not further lower my average glucose because liver sugar output and insulin response are already under control, so they are not what determines my glucose level anymore. In short, the drug has little remaining leverage. After the stroke, counteracting forces likely emerged, including stress hormones, autonomic imbalance, reduced physical activity, and neurological recovery demands. These factors would normally push glucose higher. The absence of expected glucose elevation during this post-stroke period suggests that the underlying metabolic control structure remained intact. Metformin likely buffered these new stressors, helping prevent glucose from rising rather than lowering it further. Therefore, the unchanged EEG does not indicate drug failure. It indicates system saturation. The metabolic system was already operating near its achievable floor given physiological constraints. Interpretation based on results only without debate from a scientific perspective. This result is straightforward. If metformin were the main driver of my glucose control, my average glucose should have dropped after the stroke once the drug was started. That did not happen. This indicates that my glucose control had already been established through long-term lifestyle adaptation before medication was added. What this does and does not mean, this result does not imply that metformin is ineffective in general. It does not challenge its usefulness in other patients or populations. It does mean that in my case, metformin did not provide or show any additional glucose-lowering benefit beyond what had already been achieved through lifestyle control. At present time, my glucose control is behavior-driven, not drug-driven. The data show that my body does not rely on metformin to maintain my current level of glycemic stability. Conclusion: longitudinal CGM data from two extended periods, one with lifestyle control only and no medication, and another one with combined lifestyle control and metformin, show nearly identical average glucose levels at approximately 113 milligrams. This finding demonstrates that my glucose control was already established prior to medication and remained unchanged after medication was introduced. In my case, diabetes control is sustained by my long-term lifestyle habits rather than pharmacologic intervention. The data speak clearly, without the need for interpretation or debate. I was trained at MIT to trust what I have seen with my own eyes and measured with my own data, not what other people say. Data do not lie. Disclaimer: I write this paper not for fame, but to share what I have learned so others can understand their health, prevent disease, and live longer, healthier lives. This content is provided for educational reference only and does not constitute medical advice. No doctor-patient relationship is created. You may share this summary freely, but it must not be altered or republished as your own. All intellectual property rights belong to the author, Gerald C. HSU.